And welcome to this edition of McKnight's Live, where we interview thought leaders about important issues in long-term care. I'm Kim Marcellus, Senior Editor of McKnight's Long-Term Care News, coming to you from LeadingAge annual meeting in Nashville. I'm joined by Nicole Fallon, Vice President of Integrated Services and Managed Care for LeadingAge, and one of the foremost experts on Medicare Advantage plans and the challenges they present for long-term care providers. Thanks for stopping by during this very busy week, Nicole.
Well, thank you. It's so nice to have you all here.
Well, we've worked together for a couple of years now, and I mean that when I say you're a foremost expert. Really appreciate your insights. I guess let's just start kind of broad, big picture question. What are you getting as message from your providers that you work with? What are their most salient concerns around Medicare Advantage plans right now?
Sure. So payment is always going to be number one. And some people might suggest we're whining, but I think there's a lot of evidence that there really is inadequate payments. What we're seeing and what MedPAC has said is the plans are being overpaid by 22%, and yet they are underpaying us by like 20 to 50%. In some cases, they're offering our providers Medicaid rates to provide skilled level of care, which is a much more resource-intense type of service. So that's one of the big concerns. In addition, at the same time that they are underpaying these providers, both skilled nursing facilities as well as home health agencies, what we're seeing is increased administrative burden, like by a factor of 10, right? Because for every plan that you contract with, you have a different set of processes, a different portal that you have to enter prior authorization data into, claims data into, and everybody's got what they will pay for and what they won't pay for. So it's not as straightforward as Medicare fee-for-service in a lot of ways. Those prior authorizations are a huge administrative burden, and I'm sure we'll talk more about a little report that came out last week.
But we'll absolutely get to that.
The last thing I'm going to say, though, is I think one of our big concerns, too, has been really lack of transparency and accountability. The plans seem to be able to act with impunity to a degree, and I don't think CMS would agree with that perspective. But, the CMPs are, when an audit is done and they actually see something has happened that shouldn't have happened, those CMPs are very high compared to like what nursing homes incur when something isn't working right. So we would like to see a lot more data collection to really help with those oversight and that enforcement function.
Okay. So let's start on the skill side. I know we've kind of talked in the past about the idea that MA plans should really provide skilled coverage at the same level or the same access to care as traditional Medicare. So at one point, I think you were feeling a little jaded. CMS gave the plans a talking to, and I think maybe last year you said something like some of the internal documentation from the plans seemed to indicate they didn't really respond to that threat from CMS. So what have you actually seen versus what you feared? How bad is it?
So I think one big focus for us this year has been around that enforcement. We got kind of excited about the calendar year 2024 Medicare Advantage rules that came out. We felt like we had commented, talked to CMS, made some strides around prior authorizations, limiting them to just figuring out what the diagnosis is, confirming medical necessity. And then there was this new language that got put into play called course of treatment, and said a prior authorization should cover a course of treatment. Now, Meena Seshmani has certainly talked about that publicly, that meant in their minds that prior authorization would follow across sites of service, and there shouldn't have to be this constant churn of these additional requests for services to be approved, continued, et cetera.
Okay.
And I started out my year in 2024 with CMS on the phone talking about how we could help with enforcement, and we said we'd continue to collect data from our members. Unfortunately, the plans were telling our members we don't see anything that we have to do any differently. And when you look at the large plans, which cover 60% of enrollees, so Humana and United and Aetna, we haven't really seen a change in practice. So we're still seeing a lot of prior authorizations, and for skilled nursing, it's almost not the prior authorization, it's these concurrent reviews, this sort of reauthorization request that we have to do. So if a plan approves 7 days, we have to come back and usually every 2 to 3 days submit another request with another 100 pages of documentation, the whole EHR record to prove why that person needs to stay. And unfortunately, I have situations that got escalated up to me that I had to take directly to CMS because there were individuals that were going to get cut off of care who were still in the middle of an IV treatment therapy.
Which you need to be doctor, in a facility to receive.
I mean, it's a skilled level of care. And yes, there may be cases where some people could receive that outpatient, but somebody that needs it 3 times a day, like every 8 hours, there's no home health aide coming out to do this at 2:00 in the morning. And there isn't an outpatient place that's going to be available, not to mention the transportation. And it is a skilled covered service. So I think the big concern is you started this with, Medicare plans or Medicare Advantage plans are supposed to follow Medicare regs, and CMS reinforced that with this rule. And yet what we're seeing is they either aren't following them or they just are ignorant of them. They don't seem to know what skilled care is.
Well, you mentioned cutting off care during a stay. I know that was a big focus of, I think, a couple of congressional hearings within the last year or so. Let's go to the Senate report then. It was, I thought, pretty damning. I know Katie Smith-Sloan from LeadingAge's referred to it as explosive. Were you surprised at the findings and or how far they went in some of the language used, either in the report or by Senator Blumenthal along with the report?
So if one can say they're thrilled to see a report that says that the number of post-acute care prior authorization requests are dramatically higher in just 3 short years, that the number of denials in post-acute care outstrip the number of, overall denials that those plans are making through prior authorization. I guess we were thrilled to see that because it reinforces what we have been saying to CMS, to Congress, to the Office of the Inspector General. We've taken our message everywhere. That this is on the rise. That's part of that administrative burden, but it's also not good for the beneficiary who sits there and doesn't know from day to day, am I going to still be here or am I going to have to pay out of pocket?
And may not be in the position to make those decisions or understand the process themselves.
Because none of us are great decision makers when we're sick, right? So that part was, I don't know, vindicating, I guess, in one sense, because there's this outside source and they based it off of data from the big 3 plans. How they got that data and some of the information they got, that was surprising. I do think it was a little surprising how far they went, that the artificial intelligence, even though they're seeing mistakes, higher denial rates, that the plans are continuing to move forward with it, and they're doing it primarily for financial reasons. That was pretty strong language.
Yes, and some great quotes from documents and from sources kind of citing how they tied it specifically to maybe we can scale this back. No, maybe we won't because it'll be too much of a hit to the bottom line. I was surprised to see some of that language in there.
Yeah, it was. I couldn't be happier to have what we've been saying reinforced and to have, an unbiased resource saying that.
Yeah. So one of the things the report recommends, you already touched on this, is more transparency and asking CMS to collect more data, which could eventually be used for enforcement. I know that you guys have talked about this before, both in a request for information to CMS and just openly about how can we judge what the plans are doing if we just simply don't know. So, what's your response to that aspect of the report? And do you think we're going to see some more data collection activity?
Well, we will see more data collection activity because there were some rules that were passed that will require it in the next couple of years, especially in the prior authorization space. There's some inconsistency between the interoperability and prior authorization rule that got finalized this last year and some legislation that is moving through Congress. And I hope we've got to a point where it could get passed by the end of the year. And that one's that Seniors Timely Access to Care Act. So we will see prior authorization data collection increase. What I'm concerned about is some of that language says that where they're going to report this information will be on their own plan websites. Not really useful for consumers, not aggregated to use for determining trends and using for enforcement purposes. So we would like to see that information reported into CMS. To be fair, CMS has also put out some new data collection kind of proposals that we've also responded to on at least the initial service determinations, those initial prior authorizations and appeals. So we did comment in on that as well because, as I said earlier, those concurrent reviews are really where a lot of the action is, so to speak, and where people are getting cut off of coverage, and where a lot of the appeal activity is too, because it's that last day of coverage notice that is getting appealed. I've heard several cases now where that has been appealed like 9 or 10 times because the plan will reissue the minute it's overturned. The very next day, they will issue another notice of Medicare non-coverage. So there's going to be more data. I think we'd like to see the prior authorization data be a little more consumer focused and used for enforcement. So we think that really needs to go to CMS and not just be on the plan sites.
Okay.
And maybe on Plan Finder too.
I was going to say, would you like to be part of the shopping experience for the beneficiary? Okay, great.
And in the data RFI comments, we even suggested there be kind of a consumer experience scorecard that included things like this, as well as length of stay in a skilled nursing facility. What does that look like in MA? If you're really evaluating your options, am I going to stay in fee-for-service or choose an MA plan? I want to know what that experience is going to look like and how it might differ.
Yeah, and if I'm torn between two MA plans, I should know which one might deliver a little more successfully if I need that level of care.
I think one area, though, I would say where we're not seeing, we are seeing some activity, but we'd like to see more, is on the encounter claims data work, because we think that if the plans were completely and accurately, filling out the encounter claims information, we might have better data that MedPAC could use to help kind of establish whether or not what the plans are paying providers is truly adequate. That is one of MedPAC's roles, but they can't do it right now because the data is not there.
Okay. All right, let's keep moving. So let's talk about, I know there's so much here. We could really do this for hours. What are the biggest pain points that you continue to hear about, particularly from skilled nursing providers, but also from maybe their families that your providers work with and clinicians? Maybe we can talk a little bit more specific, some prior authorization or denials. But the other part of that is, how do you use what you're hearing now to move your advocacy forward on these issues?
Right. I think some of the challenges is one of the things that members have brought up more lately is we're starting to see lots of plans have portals that we have to submit prior authorizations and claims through. The challenges with those prior authorizations that often you want to talk to somebody on the other line, have that peer-to-peer discussion. And we find that increasingly we are being told to just go to the portal, the answer's in the portal, there's no person you can talk to. So some of that seems to be supported in even the Senate report that they were scaling back on some of the customer service functions, the human reviewer functions. But we are definitely seeing that in different markets around the country. So that's concerning because, this would be so easy. Managed care would be so easy if we could just have a conversation. Like, it could work. But now we've got all these systems in place that are really designed to place barriers in front of things. And the report even said that they were at one point, one plan advised, don't give the provider any guide, any clue, don't answer their questions, just ask them questions and take in whatever they tell you. And we've found that even when we submit data, things get missed all the time. And that's one of the biggest issues, because continuing care might not be approved because the plan missed something when they were reviewing it. And we have no way to hold them accountable. So this is one of the reasons we've been really advocating for a provider hotline where we can report in these trends. The only thing CMS is using right now is complaints that come in from consumers through Medicare, 1-800-Medicare. We would like kind of a provider channel because we think we see that. And often consumers aren't as confident that they know the rules. Sometimes they think the plans know better. So they don't always challenge things. But that doesn't mean that there aren't issues and there aren't people being kept from care that is medically necessary and that they're eligible for.
One thing I didn't necessarily intend to ask you about, but again, we've spoken about it in the past, there was a new appeals mechanism put in place, correct? Where there was some oversight if I get denied. I think previously it always was just you were appealing to the plan itself. Was there a change in that recently, and how's that going?
There is a change that will take effect in 2025.
So
that
it's
was
not
part of
going
the
yet.
2025 MA rule, and it will help those in skilled nursing facilities because basically you had to submit your request for an appeal within 24 to 48 hours. So if you didn't get it right away or you didn't have time to discuss it with your family or something, there could be a delay, and then it would just revert back to the plan decision. This way it moves to the independent review entity, which is usually a quality improvement organization.
Okay, so that's some potential promise or advocacy work coming to fruition starting in January.
Yeah, I think that will help. I think that'll be a better process.
Okay, great. So let's finish on an issue that I'm just learning about, and that is particularly around flex cards.
Yep.
You can also talk about any other kind of emerging issues. I'm sure there are others, but what are the implications of these flex cards? Maybe for some of our audience, what are they? And how are they becoming problematic for some beneficiaries?
Sure. So within Medicare Advantage, plans, long convoluted process, but they get rebates basically if they bid under the benchmark. And those rebates have to be used to provide what's called supplemental benefits. There are lots of different buckets of supplemental benefits these days. So it can help with premiums and cost sharing and things like that. But in this case, these flex cards, flex benefit cards, are a specific type of benefit, and they are more likely to be used for people that are eligible for special supplemental benefits for chronically ill, or through the value-based insurance design program. Both have acronyms, of course. So they're sort of targeted populations. They're either low income or they're chronically ill, most likely duals because of the chronic illness. But they are eligible for kind of a monthly or an annual allowance through the plan. And then there's a menu of services that they get to apply that allowance to. Now, that can cover a lot of things. Over-the-counter meds or other over-the-counter supplies that you might need. Great service. It might provide groceries. You can get help with groceries. But they may say you can only get groceries at Kroger's down the street that is not on a bus line, which doesn't really work for you if you're in affordable housing and don't have transportation. So you have this allowance, but you can't always use it. The other thing that it can be used for, especially for those who have chronic illnesses, is they can apply it to these social risk factors. And stable housing is one of those. So they can help with rent. They can help with utilities. This is where we get into trouble. So what we have seen is in a couple of ways. Number one, the plans are using these flex cards, which are very attractive. In Pennsylvania, we heard that the monthly benefit, $450 a month.
Wow.
Now, to somebody with not a lot of means or just living off of Social Security, $450 to have access to those additional benefits, really attractive.
And I assume that's advertised very strongly when they're marketing.
Of course it is. So they enroll for this, but they don't know what the trade-off is. Sometimes it's somebody in a PACE program, a program for all-inclusive care for the elderly, where they are a dually eligible person for Medicare and Medicaid. They're getting an integrated product for all of their services, but they see this thing and they're like, "That I could really use that." They don't even realize sometimes that they are disenrolling from their PACE program, losing that integrated benefit and moving into a Medicare-only plan. And so it comes as a bit of a shock. And so we've been advocating for some changes and a little bit more confirmation that people actually know that change that they're making. Sometimes they think it's like signing up for a gym benefit.
So they think it's on top of PACE potentially without realizing. And would the problem be because if I'm in PACE, I have certain providers or access to certain benefits, and if I switch to Medicare, those change, even my providers might change?
Yes, exactly. On the affordable housing side, what we're seeing is because sometimes these cards can be used for rent or utilities, there's not really a good federal policy to say whether or not they should be counted as income. And when they get counted as income, that can impact the amount of rent the person has to pay. So the challenge is some of our affordable housing providers can't even use these cards. Like they don't take credit cards for rent. So that part is designed to help you pay your rent. You can't actually use it for rent, but now we are going to count it against you because we're going to count it in your income, and that increases your rent. So not only did you not get the help, but now your rent is even higher than it was before. That's a big concern. And we're starting to see this also potentially jeopardize other government assistance. Like SSI income through states, and Medicaid sometimes.
Anything through which your income is your eligibility.
Yep, probably. Exactly. So we've been advocating, just because it's simplest in policy, that just need a clear federal policy that those don't get counted towards income, because number one, we don't know if people are actually using them or if they can use them for the purposes. And we just need a clear policy, because people are enrolling in these plans not knowing that they're jeopardizing, just by this flex card existence, they're jeopardizing their government assistance.
Okay, so I think I skipped over one question, but I'd like to come back because this is obviously something you're advocating on. You talked about payment. 2026 rule could drop at any time. I think the 2025 rule dropped while we were at the show last year.
Yes.
Any thoughts? Just crystal ball. I know that's a theme for you guys in some of your presentations this week.
Exactly.
Any ideas on what could be or should be in that rule starting January 2026?
Well, I can say we had hoped that there would be some more clarity on prior authorizations in post-acute care. I don't think we're going to see that, unfortunately. What I do think could possibly be in there might be some of the adopting some of the ideas that came forth as part of the comment period for the Medicare Advantage data requests for information. Those were due back in May. They would have had enough time to kind of look through those and see if there were some good suggestions or things that supported direction they were already heading. So that might be, it's interesting because the rule's been sitting at OMB for a little while,
Yes.
and we had heard early on that it might be released early September, and now here we are. I think now it's going to wait till the election. So I don't know if there'll be anything on flex cards. We've certainly tried to get out once we knew that this was an issue and talk to the administration about that. And I know they were aware of it at the time that we talked to them. So we'll see if there's anything in there on that. But yeah, it's a little bit open. We'd love to still see that provider hotline in there, but I think we're running into some resistance right now.
Okay, well, thank you for all of this. Certainly so many issues across the continuum.
Absolutely.
But I will call you when 2026 comes out and we'll have another great conversation then. McKnight's will, of course, obviously be reporting on those developments, and Leading Age, I know you'll be taking care of your members. Thanks for joining us for this very first McKnight's Live. And we hope our audience enjoyed it, and you'll join us again next time.
Thanks.